we're going to start a very interesting session, and our first speaker is a very important speaker, Professor Katariina Laine. She is the head of department and professor at the University of Oslo, head of department in Obstetrics and Gynecology, and she will give us a talk on a very important issue that is perineal trauma.
Here it is. Thank you for the invitation. It's a pleasure and an honor to be invited to your first conference. My topic today is obstetric perineal trauma. I have no conflicts of interest. I'm going to go through the classification of perineal trauma, a little bit about the evaluation and diagnosis, consequences for the woman, prevention, education, and repair. First, the classification. It's recommended by WHO that we use this classification with 4 degrees. The first and second degrees are not affecting the anal sphincter muscles, and the degrees from 3A to 4 are affecting the sphincter muscles, and these injuries have an effect on the woman's health later in life. The largest injury is the 4th degree with the opening, can I point it with this? With the opening in, no, it's not working, between vagina and rectum, which also is the highest risk for later anal incontinence. There are other measures that are commonly used instead of 3rd and 4th degree perineal injury, like obstetric anal sphincter injury, or shortened to OAC or OACs. These are very common measures, but the old measures, total rupture, partial rupture, are not recommended to use anymore because they are too unclear what they actually include. So the evaluation. The diagnosis is important to do right after delivery, and to do the diagnosis you have to know the anatomy, of course. So these are the muscles that you have to recognize in the pelvic floor. And in the middle is the crucial point where we don't want to have the rupture, because there what the 3 muscles meet in the perineal body, and it can be difficult to identify which is the external anal sphincter muscle and which is the bulbous prognosis muscle. It's difficult to find good pictures or illustrations in the literature. This is an illustration that my husband has drawn to me for these purposes. But if you Google in the internet, you can find some better pictures than you find in textbooks, actually. So, primary diagnosis is crucial so that you can offer the primary repair for the woman. And careful clinical examination is necessary for all women who have given birth vaginally. All women has to be carefully examined. Also, women who have given birth several times. You have to have good visualization with good light and with good lighting, and rectal exploration is crucial so that you can be sure if there is an injury in the rectal anal sphincter muscles or not. And this is also recommended by the Royal College of Obstetrics and Gynecology. All women given birth vaginally should be offered rectal examination. Perineal and endoanal ultrasound can also be used. OACs is the most important risk factor for female anal incontinence. About half of the women have anal incontinence later in life. It's also causing pain and discomfort and sexual problems and even psychosocial disorders for women who experience this injury. Long-term prognosis is not very good. Women who have persisting anal incontinence 1 year after delivery often have a permanent anal incontinence. The secondary treatment alternatives are many: secondary sphincter repair, electrostimulation, bulging treatments, muscle transplantation. Many of these treatments have a short effect, reducing the anal incontinence, but most of them have a disappearing effect after 2 to 3 years. So the best is the prevention to avoid the OASIS incidents. So the preventive methods. Again, the most important risk factors are for being first-time mother, giving birth for the first child, nulliparity. Instrumental delivery and increase in birth weight, large baby are also important risk factors. And then, of course, shoulder dystocia, prolonged second stage, and midline episiotomy. But most of the women suffering from OASIS have a normal-sized baby and a spontaneous delivery. When you're thinking about the mechanisms why a woman gets this injury, think about the fetal head, the size, the circumference, the presentation, the speed, how fast the baby's head is expulsing, and the direction. Because the direction has to be, as you see here, the baby is going upwards. And that's the movement we need to help so that the pressure to perineum is getting less. And then after the baby's head is born, also the shoulders can damage the perineum. And this is the way the baby is coming, first down and then up. So remember the physiology when you're delivering. This is what happens with perineum during labor. The pictures above show the situation of perineum before the head is crowning. And the pictures below show how the perineum is stretching when the head is crowning and pressing down. So the most stretching happens in the middle of the perineum. And that's where the sphincter is, and that's what we want to avoid. And this is where we can do preventive methods by reducing the pressure to perineum. It's in a way simple. Remember the perineal protection with 2 hands. Communicate with the mother not to push too hard or not at all when the baby's head is coming. And use the episiotomy only restrictively if you use it cut with 60 degrees. This is the method that I am promoting and that we use in Norway. The left hand is lowering the baby's head. The right hand is protecting the perineum, and you have to always use both hands in the same time. And I'm showing you a series of pictures of an instrumental delivery. You start as usual, pulling downwards and then upwards. You see this doll doesn't have any perineal tissue, so you should think that there is still perineum. And now I'm pulling upwards. Then I turn my left hand around to slow the baby's head from crowning. I stop pulling, and now the delivery is like a spontaneous delivery. I never pull out the baby's head with the instrument. Slowly, 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 very carefully here now. I'm talking to the woman, don't push, don't push. Use some minutes here in the last part. After the baby's head is born, we protect the perineum when the shoulders are delivered. Squeeze from the sides so that the shoulders don't injure the perineum. This method can also be used in alternative birth positions like left lateral, which is quite popular in Norway. Remember 4 things: your left hand, your right hand, talk to the mother and think about episiotomy, but use it wisely only by indication. We have made an animation of this method, and it's available in the internet and YouTube, and we also have the voiceover in Arabic, if you want to look at it. It's about some minutes, maybe 4 minutes. Episiotomy is a common cut in obstetrics. It should only be used by indication and not routinely. If you cut it, please use at least 60 degrees angle from the midline, because if the angle is too small, the mediolateral becomes a median cut. And the median cuts increase the risk for oasis. Mediolateral and lateral protect from oasis, especially in newly parous women and instrumental delivery. And this is how episiotomy looks before and after the baby's head is born. So the angle becomes much smaller after baby's head is born. This is how it looked like in Norway. The purple line is Norway, and this is oasis calculated from all vaginal deliveries. In 2004, our oasis rate was 4%. And the health authorities criticized us, obstetricians and midwives, that you have to do something. This is not acceptable, since your neighbor country, Finland, has much lower prevalence. And we worked hard for many years, and now it looks like this. We have reduced the oasis rate from more than 4% to 1.6% in Norway. Somewhat lower in our hospital, where we are working even more intensively to do this. And our neighbors, Denmark and Sweden, have followed us. We have been teaching there, and they are also showing some results. And this is how it looks like in my hospital. You see the red line is the oasis rate in all vaginal deliveries. The green line is the spontaneous deliveries, now less than 1% oasis, and in vacuum deliveries we are on less than 3% oasis now. We started from 11%. Education is important. Remember to educate in anatomy, in the diagnostics methods, preventive methods, and repair. Train all midwives and doctors, no exceptions. Everybody has to be trained, young and old. Nowadays we have many methods we can use in education. We can have e-learning, animations. Hands-on training is also important. Models, animal bottoms can be used, and in the end, bedside training too, of course. This is a picture from our research project in Palestine, where we started educating the diagnostics first, and you can see that the oasis rate went from 0.5% to 4.3% by education. We educated the midwives and doctors to detect the oasis. And the blue line with the higher prevalence shows the research hospitals where we had research fellows who were enthusiastic. And the red line is from the other control hospitals who didn't have a research fellow, and they didn't find so many oasis that the research fellow hospitals did. So teach with enthusiasm. Repair, 2 methods can be used, end-to-end and overlapping. There is no difference in anal incontinence later in life. When during episiotomy and second-degree tears, continuous sutures should be used. They are less painful and you use less material. And these pictures also you can find in the internet. There are lots of instructions how to use the continuous sutures. Many women are troubled after oasis. It's important to avoid it. Educate with passion. Be engaged, or find somebody in your clinic who is engaged and do it for you. It takes time to learn good methods, so keep it going at least a year. Be careful with the diagnosis to find all the oasis so that all women can get the primary repair, and use the technique for repair that you feel comfortable with. Shukran. Questions?
Thank you very much for this very important presentation. I think, if I may just add a comment that you emphasized already, I think that attending educational courses on perineal repair should be mandatory for anyone who practices in labor ward. I think that you are absolutely right. Are there questions from the floor? I'm sure that you might have...
There is the question?
I think that is there. Dr. Katariina was wondering, are there any pre-delivery measures which can be taken to prevent these injuries? As in perineal massage. We also have these bulbs which can be helped to distend the perineum, which is sold as if you're doing a simulation of a delivery, especially for a first timer, right? And also, we are moving away from episiotomies, showing that it has not been beneficial, for the greatest number of women, and routine episiotomies don't have any place in modern obstetrics. So just your comments on that.
The perineal massage is studied a little, not very much, and the results show not so very good results. Some studies show that if the women do the massage themselves the last month in third trimester, you can reduce the risk of episiotomy a little, but actually not the risk of oasis, unfortunately. Perineal massage during the labor, when the woman is pushing, there are no good studies showing any effect of that. But this is a tradition we have been doing for a long time also in Scandinavia. We don't do it anymore. I think it's about 15 years ago we stopped at that because we haven't seen any effect of that, and it can be very unpleasant, uncomfortable for the woman.
Any other question? Well, in the meantime...
Behind, there's a question behind.
Do you see a significant difference between practice of obstetricians and midwives with your episiotomy rate in your hospital?
Sorry, I didn't hear the question actually.
I wondered if in your hospital, is there a significant difference between obstetricians and midwives performing episiotomies, routine?
Yes, we have seen that, and we have made a study on that too. And midwives cut much shorter episiotomies, smaller, and maybe more with less angle too. So the doctors cut larger angle and much longer and bigger. But in Norway, doctors deliver only in the instrumental deliveries, never spontaneous deliveries. Midwives do all the spontaneous deliveries. But yes, we can see the difference.
Thank you, Dr. Katariina, for this presentation. I just want to ask, in an environment here in Bahrain, when we have routine sort of episiotomy, how we can move from routine episiotomy to some sort of selective episiotomy?
Sorry, I can't
how we can move from routine episiotomies to selective episiotomies?
How to go from routine to selective? Well, that's a hard work because we medical professionals, we like to do things as we always have been doing, so this is very difficult. But in Scandinavia, we have managed to reduce the episiotomy use from 80% to 10, 15, 20% during many decades. And we have had a research project in Palestine in 6 hospitals where the indication for episiotomy was to be a nulliparous woman. So all nulliparous were cut. We managed it there too. It's education, and if you do it in the same time when you implement the hands-on perineal protection, it becomes more understandable that you don't have to cut everybody when you see that perineum is stretching when the delivery is slower. But it's hard work to change us medical professionals.
Yeah, because most of the time, midwives or even conducting doctors, they will be afraid. They don't want to create 3rd or 4th degree tears, and they don't want to go in litigations because they didn't do the episiotomies, that sort of things, because they will be blamed. If a patient had 3rd or 4th degree, they will be blamed why you didn't give episiotomies. They thought it could be protective. So that's the problems actually. And if any things happen, nobody will say, oh, because there were some studies recommending selective or routine episiotomies. That's the problems that we are facing in this environment or in these institutions.
Listen, and I believe in education and discussions in the unit, so that if you arrange meetings and discuss openly all these things with the midwives and the doctors together and think about what's best for the patient, what's best for our women. So I think that's the way to go.
I think that, if I may add a comment, that certainly episiotomy will be, the appropriateness, when to do episiotomy will be one of the most interesting field of research in the future. In Europe, there are different realities. In Italy now we live in a period where midwives are reluctant to do episiotomy. They've got this sort of hands-off policy for labor. And even for operative vaginal delivery, they are reluctant sometimes, and that may cause real damage to the perineal.
In Oslo, our midwives who use the hands-on perineal protection with 2 hands all the time, they cut less than 5% episiotomies, almost never, only with some few exceptions. So in normal spontaneous deliveries, it's very seldom you need to cut. But it's a long way to go from 99% to 1%.
Okay. Sir, thank you for the presentation. I have a question. Okay. There's a question, small question. Is there a specific nerve injury in spontaneous delivery or in instrumental delivery?
What did you say? Specific?
Nerve injury. Nerves. Nerve injury.
I don't hear the word.
Nerve injury. Nerve. Neurons.
Nerve injuries. Nerve injuries. Is there any specific?
Like pudendal nerve or?
I can't hear the word. What is it?
He's talking about any nerves injuries.
I'm very sorry.
Good point. Of course, the perineal nerves, the pudendal nerve can also be damaged because of the stress. And I think it's quite common, even though we don't assess it and we don't register it. But many women experience, or some women experience anal incontinence shortly after vaginal birth, and then after some months they are fine again. So that might be the nerve injury. So, unfortunately, many of them are reversible.
But if I can add something, in terms of neural damage, sometimes this is just caused by an overstretching that is determined by the crowning or the timing of the second stage of labor, not necessarily by a tear or an episiotomy. Sometimes it's just the timing. There are very nice studies on that, there is a huge overstretching, particularly when the second stage is longer than 60 minutes. The overstretching of the pudendal nerve can have permanent damages.
Thank you. So may I introduce Professor Diaa Rizk, the head of Department of Obs and Gynae at the Gulf, and the chairman of the conference of the first conference in Bahrain. Mr. Professor Diaa, would you?
Thank you very much, Abu Bakr and Stefano, and thank you everyone for attending. I'm sorry I'm not participating in the chairmanship. I'm leaving it to very good hands because I have to be involved in organization. If I make one single comment quickly about nerve injury, there's also traction injury. Traction injury because of descent of the perineum during delivery. This causes traction of the pudendal nerve. So there is traction, compression, and stress. There are 3 factors that cause nerve injury during vaginal delivery. The topic of my presentation is evidence-based surgical treatment of prolapse. I'm going to discuss traditional repair, briefly explain the concept of mesh repair, but I'm not going to discuss any surgical procedures, just evidence-based practice in traditional repair. These are my disclosures, and I have no commercial affiliations, or financial relationships. These are my various positions, which poses no conflict of interest with this presentation. I'd like to start my presentation with a statement from an anatomist, Karl Litzmann, German anatomist, in his book called Die Foramen des Beckens, or Foramen of the Pelvis, which was written in 1861. He said that the pelvis fulfills more extensive functions in the female body than in the male. I think this is very important. The female pelvis is unique as compared to the male pelvis because it shelters the largest part of the sexual apparatus in addition to the lower ends of the intestinal canals and urinary passages, and thereby assumes a greater importance in reproduction. The male pelvic floor has minor role in reproduction as compared to the female pelvic floor. We all know that pelvic organ prolapse is a dynamic condition. It may regress spontaneously as well. This is very important to remember this. And surgically treated prolapse represents the severe end of the spectrum. There are many other surgical modalities like pelvic floor physiotherapy, for example. And we must bear in mind that the direct cost of surgery is expensive. This is a study in the US in 2013. The cost of direct surgery for prolapse was more than $1 billion per year. Quite expensive. Although we consider repair of prolapse a safe procedure, and the perioperative death is usually very low, 3 per 10,000 operations, we do not always include indirect operative death, that is death that occurs after discharge from the hospital, such as pulmonary embolism or myocardial infarction. And this may be common in prolapse surgery because most of the women are elderly. We know, of course, that the prevalence of prolapse increases with age. I'm not going to discuss this, but the changing demographics that we have now with the world population in both developing and developed countries will result in more patients presenting with prolapse, and the demand for healthcare services is expected to increase. That's why urogynaecology is a very popular subspecialty now, because there is a demand for healthcare services related to prolapse. This is the photo of Howard Kelly, the famous Howard Kelly. He was an American surgeon working in Boston, and he pioneered the vaginal repair of pelvic organ prolapse. He died in 1953. He thought he invented a very good surgical procedure. I'm not sure whether he expected all this controversy now. But anyway, what are the controversies in surgical management? For apical vaginal prolapse or uterine or vulvar prolapse, should we do abdominal sacral colpopexy or sacrospinous colpopexy vaginally? Should we do a vaginal hysterectomy in all patients or preserve the uterus and do repair? And after doing vaginal hysterectomy, which type of procedure do we do? McColl colpoplasty, uterosacral ligament plication, or sacrospinous colpopexy? For anterior wall prolapse, the classical debate is whether to do traditional repair or traditional repair augmented with a graft. And if we decide to do paravaginal repair, should you do this abdominally or vaginally, which is a defect in the lateral part of the vaginal fascia. Posterior vaginal wall prolapse, the same arguments hold true, but also in colorectal surgery, they have a technique of repairing posterior vaginal wall prolapse transanally, not like our technique in gynecology transvaginally. For any type of prolapse, should we do, if we decide to do an abdominal repair, laparotomy, laparoscopy, or more recently, robotic approach? Occult stress incontinence, I'm not going to get into this because of the interest of time, but if we have occult stress incontinence, that means stress incontinence hidden by prolapse. If you reduce the prolapse, you'll have stress incontinence. If we decide to do a prolapse operation, should we repair stress incontinence at the same time or wait after surgery and see what happens and then repair stress incontinence if it persists? Should we use native tissue or grafts? And which type of graft to use and which type of suture should we use for repair? Again, we tend to forget what are the objectives of surgical treatment of prolapse. The primary objective, we're not trying to restore anatomy, we're trying to relieve or improve the symptoms of prolapse and any associated urinary or bowel symptoms. In some women, we might be able to restore normal vaginal anatomy. In other women, we cannot. The only way to improve or relieve the symptoms of prolapse is to obliterate the vagina. We must remember this, objectives of the operation. What are we trying to achieve? So procedures we have are either traditional repair using the patient's own tissues, or augmented repair using grafts or meshes, or obliterative procedure, we just close the vagina. Why did we start using grafts? Because definitely the outcome of traditional repair was not good. And at the same time, it was very popular to treat stress urinary incontinence by anti-incontinence sling procedures. The success rate was very high, more than 80%. So we thought we should do the same thing for prolapse. I think this idea was wrong because the urethra is completely different from the vagina. And up to now, there is lack of high-quality evidence to support the routine use of graft repair, primary repair using grafts in many professional societies' guidelines. I'm just going to review quickly two important studies. One of them is a Cochrane review by Chris Meyer et al., which was published in 2016. They reviewed 40 randomized controlled trials, evaluating almost 3,800 patients or women, and compared traditional repair versus mesh repair. They found that if you want to repair apical prolapse or VOR prolapse, definitely abdominal sacral colpopexy was better in terms of efficacy and causes less dyspareunia. However, if you do it vaginally, sacrospinal colpopexy, this is quicker, cheaper, and earlier recovery. So you must weigh evidence in both approaches. But abdominal sacral colpopexy is definitely more effective. Anterior repair, after this study, it created a lot of controversy because definitely mesh repair is more effective than anterior repair. And these are different types of meshes, you can see on the slide, and the confidence interval is very narrow, so the effect is very precise. But mesh repair has its own other problems. As far as efficacy is concerned, he showed that mesh repair is more effective than anterior repair. For posterior prolapse, definitely the vaginal approach that we use in gynecology is more effective than the transanal approach used by colorectal surgeons. I don't think they like this, but this is the evidence. And if we decide to do operation for occult stress incontinence, then definitely if we do primary repair of both procedures at the same time, this will lead to less postoperative stress incontinence, but at the expense of increased morbidity of doing two surgeries. So conclusion of Chris Meyer that we lack adequately powered randomized controlled trials. And one such trial was finished in 2016. It's a very famous trial called Prospect trial in the UK by Kathleen Glasner and colleagues. And then there's another study going on in Sweden now. It's called TVM3. Another point which you tend to forget is what is long-term follow-up. Nobody has defined long-term follow-up. We have to understand that if we compare the efficacy and safety of a surgical intervention, we must judge this over a long period of time. It's not like drug studies, measure the effect after 3 months or 6 months or whatever. It must be a longer interval. The only definition I found about what is long-term follow-up is the ICI 1999. This ICI is International Consultation on Incontinence. This is a professional body that publishes very important guidelines about incontinence. They defined short-term follow-up up to 3 months, medium-term follow-up up to 1 year, and long-term follow-up more than 1 year. How much more than 1 year, nobody knows. But I think the consensus view among most urogynecologists all over the world that if you want to describe an operation for prolapse and judge its efficacy and safety, this must be judged for over at least 5 years. I want you to go to the literature, read the literature about different procedures. How many of them have been evaluated over 5 years? Very few. This is a very important study which was published in 2013. Nobody looked at, but this was a very important study published by Funk et al. They did a retrospective view of almost 28,000 anterior or prolapse surgeries using native tissue repair versus mesh repair. They found definitely that the 5-year cumulative risk of any repeat surgery. Remember that when you do mesh surgery and you have a complication, you must do repeat surgery. Repeat surgery is very difficult and carries a lot of morbidity. So they found that the 5-year cumulative risk of any repeat surgery was significantly higher for mesh repair compared to native tissue repair. And the 5-year risk of mesh erosion or mesh removal, which is a very important problem, is 6%. And this is unacceptably high for a surgical procedure. And the 5-year risk of surgery for recurrent prolapse was similar. There was no difference in efficacy at all between mesh repair and native tissue repair. But mesh repair carried a higher morbidity. That's important. I think nobody looked at this study carefully. So I'm going to summarize now. What is evidence-based surgical management? The uterus plays a passive role biomechanically in prolapse, okay? So whether to do hysterectomy or not is not going to cure the problem. You have to repair the pelvic floor. In other words, if you decide to preserve the uterus, you can do the same procedures with the uterus in situ. So, but it's using the cervix instead of the vaginal vault. So you can fix the cervix either to the uterosacral ligaments, same techniques, sacrospinous ligaments, either abdominally or vaginally. Another point in the literature which is for me, was very surprising. We all tend to think that if women get pregnant after prolapse repair, should be delivered by elective cesarean. Okay, this is a good, scientific thinking, but there is no evidence for this. Most of the studies in the literature do not consistently show that cesarean delivery is better. And many patients came to the labor ward in labor, advanced labor, and were delivered vaginally, and nothing happened. So in these cases, individualized opinion is important, but I think most of us would do an elective cesarean. But there is no scientific, robust evidence for this, by the way. Definitely, you must, if you decide to remove the uterus, you must restore apical support of the vagina. And whichever technique you used, just use it. All of them are equally effective. Whether to the sacrospinous ligament, to the uterosacral ligaments, or then another technique in Australia, more posterior to the sacrospinous ligament, they fix it to the iliococcygeal muscle or fascia. All of them are equally effective. Round ligament suspension, when I started training, this was very popular in different parts of the world, by the way, was very popular after doing abdominal hysterectomy, fix the round ligaments to the vaginal vault. This is nonsense. Round ligament has no role in support or preventing prolapse after abdominal hysterectomy. Using routine perineorrhaphy, especially plication of the levator muscles after posterior repair, is not needed unless the woman is not going to be sexually active. This is a very dangerous technique and can lead to significant dyspareunia and a lot of medico-legal litigation, so be careful. There is no need to do plication of the levator muscles. As I said before, there is no clear risk-benefit information for mesh use, and unfortunately, many of them have been rapidly reduced in the clinical practice without proper evaluation. And that is a problem we have. I'm going to skip to the last point in the interest of time. There are certain procedures for repair of prolapse which are very dangerous. They carry high risk of injury of the bladder or the ureters. If you decide to do these procedures, then you must be proficient in intraoperative cystoscopy. You don't wait for postoperatively and ask the urologist to come and have a look. So cystoscopy is indicated intraoperatively to assess either bladder or ureteric damage after certain procedures, especially uterosacral ligament plication when it is more proximal in the direction of the sacrum itself. This is a very dangerous procedure. Also, paravaginal repair, especially if you do it vaginally. Sacral colpopexy sometimes can lead to injury during dissection of the bladder from the vagina can lead to injury of the bladder. So please, if you do these operations, suspect injury, then you do intraoperative cystoscopy, please. Obliterative procedures are extremely successful, 100% result in most cases. Should be considered in elderly and medically fragile women, especially those who refuse to have surgery, and a long surgery like vaginal hysterectomy. Concomitant hysterectomy appears to add morbidity and is useless. You are doing obliteration of the vagina to avoid hysterectomy. Okay, so it's useless. There's no point in doing hysterectomy with obliterative procedures. And the quality of life and symptoms, remember the slide about the objective operations, improve, and up to 90% of the patients are quite satisfied with the results. This is very common in countries when you have elderly population, above 90, above 80, whatever. So in conclusions, native tissue repair or prolapse is increasing. Why? Because the results are better than we thought, with proper, careful attention to the technique. And the most important thing, this is acceptable reoperation rates. If you have a problem or a complication or failure, okay, the reoperation rate is very low. Greater surgical experience, as in any surgery, is correlated with fewer complications in transvaginal mesh procedures. Some transvaginal mesh complications are refractory, very difficult to treat, even with surgery. So be careful about this. Even if it's more effective, sometimes it can cause serious morbidity. The consequences for interventions, when you compare two procedures, you have to also compare the consequences of interventions in case of failed surgery or complications. So consequences of intervention for unsuccessful transvaginal mesh surgery is not usually considered when you compare the two techniques. And vaginal mesh repair, this is my personal view, should be reserved for high-risk individuals in whom the benefit of mesh placement may justify the risk. This is a very wide statement, but it depends on your personal experience and the evidence in the literature. If you decide to do mesh repair, then definitely the benefits should outweigh the risk. I think I'll just skip this quickly. I'm sure you're all aware now of the government complications. Different parts of the world ban meshes. In some countries like Scotland, both synthetic meshes for stress incontinence and for vaginal repair were banned. This is an act from the parliament itself. Okay, so you cannot use this in Scotland. Also in Europe, mesh repairs are evaluated with a view to suspend them, and most of people in Europe, they recommend mesh to be used as a secondary option if primary surgery has failed. And it's important to consider, that's very important, that you use a larger surface area of mesh in vaginal surgery compared to stress incontinence. And this creates more complications because the risk of complications is directly related to the surface area of the mesh. Also in Europe, the sufficient data are not available. That's a recommendation on the long-term use of non-absorbable meshes for prolapse repair, and they're not normally recommended for young women because of the complications. This is not the time to discuss them, but one of the serious complications is dyspareunia. This is a prospect study, my last slide. This was a study published in The Lancet in 2017 by Catherine Glasner et al. The objective of this study was to compare the outcome of prolapse repair involving static mesh with standard repair. This is a prospective study, multi-center, single-blinded, obviously, because it's a surgical procedure. You cannot blind the surgeon. And it was randomized in 35 centers in the UK. Very properly designed study. And women undergoing primary, transvaginal, anterior or posterior repair by 65 different surgeons were randomly assigned one-to-one to either native tissue repair or native tissue repair augmented with synthetic mesh. Follow-up was only for 2 years. Obviously, it was 2017, but I think they're going to publish the studies of 5 years very soon. The studies were published 2 years after surgery. The primary outcomes were measured first after 1 year and again after 2 years, and they were subjective. Patient reported prolapse symptoms. The findings that in this study, of course, there are 865 women were included, 430 to standard repair, 435 to mesh repair, and the cumulative number of women with a mesh complication over 2 years, look at this, was 12%. And the prolapse scores after 1 and 2 years in both groups did not differ. So the conclusion interpretation, which is very important, I think this was the impetus for looking at meshes in the UK, in England itself, after the publication of the study, that augmentation of vaginal repair with mesh material did not improve women's outcomes in terms of effectiveness, quality of life, or any other outcome in the short term. More than 1 in 10 women had a mesh complication, which I think is unacceptable for any surgical procedure. Follow-up is vital, of course, longer follow-up to identify any other long-term complications. Thank you for your attention.
Professor, thank you very much for a well-informative lecture, and I open the floor for questions. Please. Microphone.
Microphone, please. Is this working? This is not working as well now.
Thank you, Doctor, for the excellent presentation. I'm sorry if you allow me to introduce myself. I'm Dr. Ghada Sumbul, a urogynecologist, and I want to congratulate you about the first conference.
Thank you.
And I'm actually here want to mention one of the people that I was mentoring for her, Dr. Anouf Bahzat, and I'm so proud that she is one of the organizers, on top of the organizers of this conference.
Thank you.
So I have a question, please. You've mentioned on your slide the rate of reoperation in patients with anterior repair who has been treated with mesh had more surgery afterward, but we didn't know what was the reason of repeat surgery. Is it related to recurrence? Because we know that use of mesh has more durable effect. Is the recurrence, repeat surgery was for mesh complication, or what exactly?
No, when you compare, most of the repeat surgeries are because of mesh complications. As I said in my presentation, I didn't mention them in the interest of time. The commonest complication is mesh exposure. That's number one, if it does not respond to conservative treatment. Second is mesh shrinkage after fibrosis. These are the most two serious complications, then you have to remove the mesh. The operation to remove the mesh. There are other complications like infections or whatever, which can be measured conservatively. Dyspareunia, because of shrinkage. All these problems are related to mesh insertion, transvaginal. I'm not speaking about transabdominal now, transvaginal mesh insertion. And because of the anatomy of the vagina, if this occurs posteriorly, then it's more significantly to cause sexual dysfunction.
I have another question, if you don't mind.
No, I don't mind, but I can't hear you. You have to speak up, please.
I have another question, please. So we know that abdominal sacrocolpopexy have a more durable effect, as you've mentioned in the beginning. Abdominal sacrocolpopexy have a durable effect, as you mentioned. So if you have a patient who came with recurrent valve prolapse and she's elderly, not sexually active, would you go for abdominal sacrocolpopexy, or you would use a mesh kit for vaginal prolapse surgery?
So you have an elderly patient with valve prolapse. Okay, that's what you said.
Recurrent valve prolapse.
Yeah.
She's not sexually active. Would you go for abdominal sacrocolpopexy?
No.
Or you can still go for abdominal mesh, vaginal mesh?
Yeah, I would do sacrospinous colpopexy. Sacrospinous vaginally. Okay? Any? Yes, please. Comments from the experts as well. Elderly women with valve prolapse, recurrent valve prolapse. Would you do abdominal or vaginal colpopexy? Elderly woman with recurrent valve prolapse.
Myself?
Yeah.
Well, I think that it's not just a young or old woman. I think that we should look at the vaginal profile. When you do sacrocolpopexy, and every honest laparoscopist can tell you that, if there is a concomitant high-grade anterior vaginal wall compartment, you cannot actually repair that appropriately. And I do laparoscopy, but sometimes I examine the patient after sacrocolpopexy, although I try to suspend it anteriorly with the mesh, but then this woman often need a further anterior repair that sometimes some surgeons do concomitantly and others do on a second stage. In our unit, our policy is that when there is a concomitant high-grade, third stage or fourth stage anterior vaginal wall compartment, we always go vaginally with native tissue repair. Yeah, I'm a very strong believer of native tissue repair.
Okay, I think I have to explain this. A lot of apical prolapse repair are actually anterior prolapses. Do you understand me? A lot of apical prolapses or valve prolapses, there is a component of apical prolapse and anterior, as Dr. Salvatore said now, an anterior wall prolapse. Okay? Combined. Abu Bakr?
I just listened to your question that this patient is not sexually active. She needs to have a lot of counseling before you do a major surgery like this. So I may just close the vagina. I give her the option of that. So that's the way how I think, because of the issue statement.
The important point to know that sacrospinous colpopexy may affect sexual function. Sacrospinous may affect sexual function. So better avoid it with other factors in sexually active women.
Thank you, Professor Diaa, for excellent talk. I don't know, we face a lot of challenges when we see at young age nulliparous prolapse. What is your experience?
Nulliparous depends on is it uterine or vaginal prolapse?
Uterine prolapse in nulliparous young girls. I've seen here 2-3 cases.
Hysteropexy. So fix the uterus to the sacrum. Abdominal hysteropexy. Sacral hysteropexy.
Even in 2 cases, that also didn't help.
I had some experience, as I said now, abdominal sacral hysteropexy, and then you should plan to deliver them by elective cesarean, okay? Even in my own clinical experience and in the literature, I've seen 2 patients coming, cervix dilated 8 centimeters. So we had to deliver them vaginally, and nothing happened. But of course, delivery should be by planned elective cesarean. So sacral hysteropexy, abdominally. Either laparoscopy if you are experience in laparoscopy or by open abdominal approach.
Any more questions?
Can I make a comment? Professor Rizk, can I just ask you a comment on this?
Yeah.
At least since 2011, any Cochrane review document clarified that the use of synthetic meshes in the posterior vaginal compartment was not advisable, was not suggested, was not indicated.
They don't say this, Stefano. The conclusion of the Cochrane reviews is not like the guidelines. They say which is more effective, which is not more effective. They didn't, the objective, whether posterior or anterior wall prolapse, okay? But definitely, for posterior wall prolapse, mesh repair does not add significant benefit compared to traditional repair.
Yeah.
Plus, they mainly compared transanal with transvaginal repair. But in Cochrane reviews, they don't spell it out clearly. Do not use this or use this. These are usually guidelines.
That's true. This is a speculation. But looking at the results that they analyzed, basically the posterior meshes should not be used. And these are according to...
It should be the same as anterior mesh, but the instance of sexual dysfunction should be more if complications occur. Should be more serious because of putting mesh in the posterior wall of the vagina. Especially dyspareunia, and if there is shrinkage of the mesh. That's what they say.
Okay, we will go through that probably.
Yeah, sure. As I said, this is a very gray area. Difference between guidelines of societies, professional societies, they say it clearly. Do not use mesh, whatever. But Cochrane reviews do not give this conclusion. Say which is more effective, because the objective is which is more effective and which carries more risks of complication. That's it. But they never say use or not use.
Doctor, I just wanted to know if there's any experience with using a person's own tissue like tensor fascial lata, for example. So what happens is we do anterior, we have a cystocele, and we're trying to use native tissue, but that cystocele is because the native tissue is already compromised, right?
I can't hear you clearly, sorry.
Okay.
Yep.
Actually, I was asking.
No, you use the microphone, but I can't hear.
I was asking that when we are doing an A repair, okay, anterior repair, the tissue over there is already compromised. That's why it has prolapsed. Now, when we try to use the same tissue, plicate it, whatever, reduce it, that's already a compromised tissue. Is there any place for using biografts like the patient's own tensor fascial lata?
Yes, of course.
We can lift large grafts which can be used, and I feel there are very few studies or units which are doing it.
All these studies, because I don't have time again, it's synthetic meshes, not biological meshes. Yeah, all of this is biological. This is a completely different story, biological meshes. Most of this criticism is transvaginal synthetic meshes, okay?
No, I was asking about the efficacy of using biological tissue from the patient to improve the outcome.
It hasn't been revised properly. There's no enough studies to compare biological graft with native tissue repair. Okay? Definitely, the only thing I'm sure of is if you use biological grafts in sacrocolpopexy, they are less effective. They're not as strong as synthetic meshes. So it is better not to use biological grafts if you do sacrocolpopexy. Definitely, this is definitely.
Professor Diaa, I'm just going to conclude by asking you the last question.
Yeah, sure.
How do you feel about the future of stem cells in the area of pelvic?
That is very important because there are excellent studies now about stem cells for deficient urethral sphincter, especially in male after doing prostatectomy. They're trying to avoid, after prostatectomy in males, you damage the sphincter, they can have stress incontinence. And treatment is linked, same as male. So there are a lot of studies, I'm aware of animal studies, that they are using stem cells to try to regenerate the urethra for the male post-prostatectomy incontinence. I don't think any studies have been done in prolapse yet, okay? But I think this is a very promising thing, especially, I think, in women who have recurrent prolapse. Definitely their tissue will be very weak. You should try stem cells to try to regenerate endopelvic fascia.
Thank you very much. I think we could close the meeting and we go for a break. Am I right?
Yes.